Good morning again. So I would like to thank the MISSAB organizers giving me this opportunity. And I would like to say sorry that I didn't know this is a session on complications. So it was sent to me that you have to present a case on challenging case. So anyhow, we'll discuss this case. This is a patient, 67-year-old male, bedridden since last 1.5 months due to severe pain in the back and severe lower limb radiculopathy along with L3, L4 dermatomal weakness around grade 3. And sensory was intact and bladder was questionable whether it is involved or not. And patient had a pacemaker with 2 stents in situ since last 18 years and non-diabetic. So this is the X-ray. Obviously, we can see there is a lytic lesion at L3. At this stage, we were really confused in the sense because there was a pacemaker which was introduced around 18 years ago, which was a old type, which we couldn't change basically the settings in it. This is whether I just present or we have to discuss the case. I'm not sure.
I think you can discuss a little.
Discuss. So can you take up the question? So what you would do then if you see such a patient?
I mean, obviously we can see some possibility to neoplastic pathology involving L3, is ballooning of the cortex. The pedicles walls are not clearly visible on that side. So more than likely, my first differential would be some neoplastic process. But as you rightly said, because of the pacemaker, MRI is not safe or feasible.
Yeah.
So the beginning with the investigation stage only, we are in a dilemma.
Yeah.
So, my choice in such cases would be to do a CT scan, second best choice. It's not the ideal, but at least we get a little bit more information than a plain X-ray.
Okay, just CT or because patient has a neurological deficits also. So, Sanjay.
I feel that you need to go for further investigation like MRI is going to give a patient got deficit with pacemaker. Sorry.
Yeah, that is the main catch.
Then
here.
you can go. Then CT myelo only.
CT myelo. Yeah. So that's what we did. We did a CT myelography, and it showed that there is a highly lytic lesion in L3, and there is basically a block at just behind the L3 body. This is Dr. Umesh. What would you do now? Like patient has a pacemaker and with neurological deficits, bedridden since last 1.5 months and with neurological deficits.
So basically now we have to understand what is the diagnosis. So that is the main thing. So I think we would have a discussion about what could be the possible pathological condition.
Yeah.
Whether the patient has any other lesions. I think an entire screening or onco-CT kind of a thing is necessary in these patients in order to find out if there are any other lesion, whether it's a metastatic or a primary spinal pathology. And if we don't find any other lesion and if this is the only lesion, then we consider probably possibilities of, aneurysmal bone cyst or some other kind of a neoplastic pathology in these cases, because the X-ray picture looked almost like an expansile lytic lesion. I think that is the way I would like to proceed first.
This looked completely lytic and bone biopsy was attempted twice and it came negative, once insufficient sample and once it didn't query plasmacytoma. But then all the blood markers for multiple myeloma were negative. So if now we are at this stage, the biopsy is inconclusive and the blood tests are not really suggesting anything other than he is just anemic 6 gram %. Dr. Sanjay.
So in this case, we need to to confirm one your biopsy is negative.
Yeah.
So twice they are done. Now the option is we have to go and rule out any secondary. You need to go for a PET scan and all this. Is it
Oh,
necessary?
okay, so this is the only lesion which we have in the spine. So bone scan was done, uptake only in L3 and some mild uptake in D12 and L1.
So, and the power is 3 out of 5 in the left leg.
Yes, yes,
So we cannot just manage it conservatively.
yes,
So somehow we have to go and decompress those L3, L4 and left-sided nerves and stabilize it also
yeah,
because there's an impending fracture.
fracture.
So, you know, more than likely from what you said that it is a very vascular lesion.
Yes,
So in such cases, I would, I mean, we don't have a diagnosis, but we have tried. So I would go for angio and embolization first, and then only consider, you know, surgery in the form of decompression and fixation, maybe vertebroplasty at that level also.
so vertebroplasty with such a lytic lesion, will you think whether you will be
During
able to do
open surgery, during open surgery,
open surgery? But
during
then, Ajay, if he says want to do open surgery, what challenges do you expect if you do a open surgery here?
As you correctly predicted, it is a lytic lesion and probably hypervascular.
Yeah.
And that is the exact reason why your biopsy has come out to be negative, because you are putting in the needle and aspirating blood which does not contain the tissue.
Yes.
So open biopsy is mandatory in this case. And taking an open biopsy without precipitating a epidural leak, that is to say hematoma, that is the main concern here. You can take a open biopsy or you can use a big cannula biopsy extrapedicularly into the lesion and put a grasper into it and take a biopsy, because you need to know the oncologic behavior of it, because for any tumor the decision making is based on norms. NOMS.
Yep.
N is neurology, O is the oncological behavior of the tumor, M is the mechanical component of it, and S is the systemic effect of it. Systemic is HB is 6, so it is already systemic. Mechanical, there is a fracture, one-sided collapse, so it's a surgical indication. So surgical biopsy is what is to be done along with fixation and final, because neurology is already affected.
Yep.
So I wouldn't have attempted the second biopsy even, and probably even directly going for the surgery and the per-operative biopsy.
Okay.
Yes, the problem I am anticipating is a bleeding.
Bleeding.
So once my biopsy is done, usually I end up using absolute alcohols in these cases and wait with that. So you put absolute alcohol, wait, that just remains there, and then you complete your job. So that is as equivalent to what is a pre-op embolization, which many cases I am not able to send in my situations, many cases, though we prefer pre-operative embolization.
So we have 2 minutes, right? 8+2. Okay. So the other problem which you expect actually with the pacemaker is you cannot use any monopolar. So if you use monopolar, that's the problem. Doing a open surgery, removing the tumor without using monopolar is really difficult. What did we do is we went completely MIS after embolization, fixed one level above and one level below, and with the basically the expandable tube retractors, did a corpectomy through this expandable retractor itself, and put a expandable cage. Did a corpectomy and put this expandable cage, and ultimately the biopsy turned out to be plasmacytoma, and radiotherapy and chemotherapy were given, and this is the post-op. You can see again the body is actually restructuring itself. So this is the challenge basically with the pacemaker, especially the modern pacemakers. You can change the mode and you can do MRI, you can use monopolar cautery. During that time you can change the mode and then again switch back to a synchronous mode. But then this patient had an 18-year back, the pacemaker basically introduced. Otherwise we had to change the pacemaker, or then we go ahead with this. So that's what we did. Thank you.